My name is Dr. Ludi Shih. I'm a neurologist. I work primarily at the Beth Israel Deaconess Medical Center in Boston, but once a week I come out to Milton, where I get to see a lot of patients in that part of the metropolitan Boston area, so I really enjoy that. I want to talk to you today about something I've been studying and seeing patients for a long time with, and that's Parkinson's disease, as well as dementia. Both of these health issues are concerns among older adults, no matter where you are, no matter what race, gender, education level. These are issues that affect all of us. And so I want to talk to you about this today, either whether or not you have any personal experience with it, or a family member or a friend, or even you hear about it in the news more and more these days. This is a topic that I think gets a lot of interest. So one of the things I think about, please come in, is when I go out in the community, one of the things I think about is, are we doing a good enough job at helping people recognize symptoms of Parkinson's, whether it's educating people to recognize motor symptoms in themselves, or even other docs like primary care doctors, nurses, physical therapists, whoever might be able to help us and help get a patient to care if it looks like they have symptoms of Parkinson's. And then I want to talk about dementia, which a lot of people ask questions about. Is that different from Parkinson's? Is that Alzheimer's disease? And I'll go over a little bit of that to clarify some concepts. And then I think as we see that the incidence and the prevalence, these are words to describe how many new cases there are of Parkinson's and how many total cases there are in the world, it is definitely growing. And so that means people like myself and the healthcare team I work with, we have to think about how do we meet people's needs as more and more have Parkinson's, and they come from all over the world. And then it is a chronic progressive illness, so there's a long duration of disease. So what can we do to improve quality of life? How can we get a team to work together to help people with these conditions? Okay, this is a little video, and with permission from the person here, we use this often for teaching our medical students, trainees. Here you see a lot of classic symptoms. Not everybody has these, but they're just useful for instruction. You see a tremor of the hand. It's this kind of thing where it's resting in the person's lap. And you can see the tremor goes away when he does this. And then he's being asked to do this. But look at mine and look at his. His is small.
Now do this.
And then when I do this motion, this is a standard task. He's pretty small and slow, and he starts to peter out. You see that?
Now do this.
And then he's asked to do this. And I'm trying, mine is nice and big and fast. He gets smaller and smaller the more he does it.
Now begin tapping again.
Same thing with the foot taps. Now, when I examine him, his strength is good. It's not like he had a stroke and he's weak on that side, right? So this is the difference between what causes one person to move slowly due to a stroke versus Parkinson's. And when he walks, he doesn't swing his arms.
And now go back.
And then when he turns, he's got to take a lot of steps to go. It's not one big swing of a movement. And you see the tremor again in the arm. And you may notice something else about his face. There's not a lot of expression. Now you may say, well, he's not an expressive guy. He's just sort of stoic. But there's commonly a reduction even of the facial muscles. They don't move as much or as big as the other muscles when we are talking about asking people to do active tasks. So interestingly, this person came in because they were concerned about the tremor, but they didn't even really recognize how slow they had kind of gotten. And this is where sometimes I find in my practice, it's family members or friends who may not want to say anything, but they may corroborate that, yeah, actually, you might not be keeping up on walks as much as you used to, Dad. And they may bring that up the first time at the doctor's visit. And it's sometimes a surprise to people I see. So here's some statistics. We think in the US right now, there are about 1 million cases. How does that compare to something like Alzheimer's disease, which I'll get to? That is about 7 times more common. But what it means is there are 60,000 new cases of Parkinson's every year across the country, and someone is diagnosed every 9 minutes. What's interesting about Parkinson's is the average age of onset tends to be a little younger than Alzheimer's. So On average, it's around 60 or the early 60s. But 10% of people get it before the age of 50. So it's not uncommon at all in my practice to see someone. However, when I see referrals come in, someone has bounced around for a little while because they're young and their doctors didn't really realize that they really could have Parkinson's even though they're age 48. That just is surprising to a lot of people. A very good example, and we've been lucky in the Parkinson's field because we've had some rather famous people develop Parkinson's, and they've done a lot for advocacy. The most famous example is Michael J. Fox, the actor. He was about 29 when he started developing symptoms of Parkinson's. So that is quite young, but not out of the question. So the other very interesting thing is that men are about 50% more likely to develop Parkinson's than women. We still don't know why, but the trends are very consistent. 60% men, 40% women. So we know that there's something going on in the brain that's somehow related to sex hormones that express how things show up in people. What's interesting about Alzheimer's and dementia, there's a little bit of a preference for women over men depending on how you look. So it really just sort of depends. But in Parkinson's, it is more common in men. So we are going to talk about how you manage the condition once you get it, but recognizing it and figuring out who's a little bit more at risk is also a really important public health issue. So as I mentioned, men are a bit more common. We have a lot of research that points towards some environmental factors that might play into whether someone gets Parkinson's or not. Certainly there's genetics, and I'll mention that in a second. And then age. As we get older, we're all going to be a little bit more susceptible to these brain aging diseases. So, about genes, it's a very common question I get, especially for people who did recall that actually they had a parent who had Parkinson's and now they've developed Parkinson's. So naturally they're wondering, did I inherit this? Was this always going to happen to me? And although it seems like it in retrospect, the answer is probably not. We don't have that many genes that strongly predict that you're going to get Parkinson's. Unlike you've heard of some genes out there, like certain breast cancer genes or another disease called Huntington's disease. If you have the gene mutation, you will definitely get the disease, or at a very high rate to get the disease. That's not really true in Parkinson's. But there are about 20 genes that we really recognize, and then I would say even from that, there are about 7 genes that we think are very much more likely to cause Parkinson's. And most people, I would say still, don't have any mutation. We can't find it on our current genetic blood tests that we give out. So having a first-degree relative, as I mentioned, a parent or a sibling, that does increase your risk of developing Parkinson's. But if you take the average statistic, your chance is about 1% if you're over the age of 65. Maybe your risk doubles to about 2%. So it's still not a big jump, but it's a relative doubling of your risk. Genetic testing can be done. There's a lot of companies that are developing drugs to get at the biological basis of the Parkinson's. And what genetic studies do is they help researchers figure out what molecular mechanisms could possibly be harnessed or stopped in order to prevent someone from getting worse with Parkinson's. That's the idea. So on a policy level, we know that there are certain pesticides and organic solvents that we use a lot in the States that actually some countries, even in Europe, have already banned. And so there's a lot of work going around that. And then other things like traumatic brain injury, and we think even maybe repetitive head injury from things like contact sports and football. You may have heard of some recent examples of this. That seems to maybe increase some risk as well. And then finally, the kind of genetic risk factors you develop, and if you happen to run into any of these exposures, might influence your risks. Sometimes it's not always clear. People could be around pesticides but never get Parkinson's, but it could be that their genetic background is somewhat protecting them from it. So this is going to be a busy slide, but I think it highlights some of the things about Parkinson's that we've really learned over the past 50 to 70 years. And it started with some bunny rabbits. This man, Arvid Carlsson, was a Swedish scientist. He was actually looking for drugs to help treat high blood pressure or hypertension. And he knew if he gave these rabbits this chemical called reserpine, he could try to, improve the blood pressure. But actually something funny happened. The rabbits began to get all slow and tremulous. And he realized, oh, I did something. I knocked down their dopamine. And soon after that, people recognized, oh, there may be a relationship between that and the fact that in the urine of people with Parkinson's, they don't produce as much of these dopamine byproducts. They're missing dopamine. Finally, this chemical structure was discovered. It's L-DOPA. For those of you who remember back to high school chemistry, actually, this is a fairly simple chemical structure. These days, these things are multi-layered and complex and might take up the whole screen. This is a very basic amino acid. And it was finally made into a drug in 1975. It's called carbidopa-levodopa. It still remains one of our most effective drugs for Parkinson's. And it led to the Nobel Prize in 2000. So how do we know whether someone's missing dopamine? Well, a brain MRI, or an MRI of any part of the body, some of you may have had, is really good for looking at structure, especially soft tissues like fat, muscle, and brain. But it doesn't tell you anything about the underlying chemical content. This scan is a nuclear medicine scan. Some people do these for their heart because they're trying to look for any places where there's stress on the heart. You can do this on the brain and with a special chemical that looks for dopamine, and this has been FDA approved for some time. And on the left side here, you're looking kind of at a slice through the sort of the top third of the brain, and these two structures have a lot of dopamine in them. And in this person who's healthy, they've got a normal sort of comma-looking shape. And in this person on the left, they're missing quite a bit of it, and so you see just kind of like two dots. And so we realize, okay, that makes sense, because back a long time ago, people knew, scientists were studying brains of people who passed away from Parkinson's. What you're looking at is a section of the lower part of the brain called the brainstem, and in the midbrain you see where the arrow is pointing. That should be normally two thin layers of black lines. The brainstem on top has them. It's literally called black substance, in Latin substantia nigra, and that's what produces all the dopamine that shows up here. And through lots of research looking at brains that people have donated and other specimens, we know that these little pink spots will form inside nerve cells. They're pink because they're stained pink, but what they actually contain is a protein called alpha-synuclein. And maybe you've heard in the news about Alzheimer's and amyloid. Amyloid is a protein that gets misfolded and gunks up, and they think that that's what's leading to some of the nerve cells dying. In Parkinson's, the analogy here, it's an analogous situation. This alpha-synuclein plays a similar role. And so that's a complicated slide that really just shows that scientists really think that normal alpha-synuclein exists in this kind of relaxed, unfolded state. But as something goes wrong, it develops into these big sheets and big rods, and they start gunking up the neuron there, and the neuron starts to die. Okay, so we talked a lot about this levodopa, which in the old days was really the only thing you could get. And we don't really know how important it is to give someone levodopa. We just give it because it really is the only thing we have. But people have asked me, well, can I take it now? Should I take it later? There's no real good evidence except to say that we're trying to make people function and feel better. But if you talk about does it prolong survival, it might, but only in the sense that back then there were some people who really didn't get it until 7 or 9 years into the disease, and that's group 3. And their risk of death is probably about 3 times higher than this group on the right, which started it within 1 to 3 years after their disease. And that's probably because their disability was probably a little bit better addressed by having some dopamine back in their system so that they could actually try to move more and self-care a little bit better. But I want to tell you one thing that's a little tricky. Parkinsonism is not unique to Parkinson's disease. What do I mean by that? As we all get older, our brains do age, and we can develop a little slowness that isn't just due to, joint pain and back pain. We all can develop a little bit of slowness. It's not so bad. It doesn't come with a lot of tremor. It doesn't come with a lot of muscle rigidity, which are the two other major symptoms of Parkinson's. But people can develop them because maybe they have had a lot of vascular disease, and vascular disease affects the heart as well as the brain. We even see this sometimes in people with Alzheimer's. And finally, there's a group of drugs that can actually block your dopamine, the dopamine you're already making. And sometimes they're really important drugs to take, but sometimes they may no longer be necessary or useful when they especially start producing a picture that looks a lot like Parkinson's. And then we now know that people, as we get older, we might develop more than just one quote-unquote disease. We might see changes of Alzheimer's and Parkinson's and other things in one brain. And then I mentioned the contact sports. It's very interesting. There have been a few prominent athletes who have developed Parkinson's. Now, it's always tough to know whether it was a coincidence or due to other factors, but Muhammad Ali, Brett Favre, the former Green Bay Packers quarterback, also recently revealed his diagnosis. So it is sort of interesting. It's not a common group of people. There are not too many professional football players in the world, but it is something that we're paying close attention to, as there are a lot of kids who are playing football these days. Okay, back to Parkinson's disease and what people might experience. So we talked about the slowness. In the medical term, it's bradykinesia. We talk about muscle rigidity, and we talk about tremor. Those are really obvious motor symptoms, but it turns out that people can develop a lot of non-motor symptoms. There might be pain, there might be fatigue, there might be bladder urgency that they can't control, or even drops in blood pressure when they stand up. And that's because the Parkinson's disease isn't affecting just nerve cells inside the brain. It's actually going on to affect other parts. You have a nervous system that controls your bladder, your blood pressure. We don't think about it. We take it for granted. But your nervous system is designed that way to take care of all those things so you don't have to think about it. But with Parkinson's, the changes can really happen, in which sometimes you need to kind of do things to kind of compensate for that. But there can be cognitive changes and increasing falls and balance issues that unfortunately the levodopa or the other drugs that help dopamine don't really address. And so we still have a lot of gaps in trying to figure out what it is that we can do to improve people's experience with this. All right, now I want to get to dementia because I mentioned it. Well, in the context of Parkinson's, but it is a really common health concern as we get older. It really is just an umbrella term for any progressive cognitive decline. Alzheimer's disease is probably the most common one, but increasingly we're realizing probably many more of us also develop enough vascular insufficiency to the brain that it's also contributing. Lewy body dementia is probably becoming more recognized because it presents pretty differently from Alzheimer's, and on top of that, it has some kind of relationship. It's sort of like a twin or a sibling of Parkinson's disease with dementia. In fact, if you look under the microscope, they're very similar. But the difference is that people with Lewy body dementia might show up first. Their friends and family members, or they themselves, might say the cognitive issues or the behavioral issues are really happening before any signs of tremor or rigidity or slowness. Whereas with Parkinson's, especially some of our younger patients, they really have just motor symptoms for a very long time and really don't develop dementia, if at all, until very late. So the cognitive impairment, what does it look like? Well, it might not just be forgetting, which everyone kind of recognizes is associated with Alzheimer's disease. In this case, it could be really mild, like having a job that used to do really well, being able to keep track of different tasks. That's called executive function, where you're multitasking. Or working memory. Working memory is different from recall memory in that you're holding a piece of information in this part of the brain to get to something else, and then you retrieve that information and say, oh yes, I remember, you told me we're going to go here, and I was going to use that information to now grab the item that I needed for that thing. So it's sort of more indirect. Visual spatial processing is interesting. We always think of our eyes as just being our eyes, but our eyes have massive input into the brain. And so when we're driving and we're judging space and speed and even kind of memory for how to get to one place from another. That requires the back part of the brain to really process those things. And sometimes people can get into trouble because that part of the brain no longer works as well. And they may even start experiencing illusions or hallucinations, things that look like an object that are not really there. And then less commonly, people will report the kind of similar language or memory problems that an Alzheimer's patient might, but doesn't usually show up very prominently. There's some statistics that say if you've had Parkinson's for long enough, the dementia might develop in up to 40 to 80% of people after about 15 to 20 years. And I think what's important to say, and I say to my patients, is just because you have Parkinson's disease doesn't mean you stopped being a regular human being too. And so that means we can still work on things that we know are helpful for probably preventing dementia or delaying it in the first place. And they can be kind of things you wouldn't expect. But even things like promoting education, that's more of a global policy issue. But even addressing hearing impairment, how many people knew that if you're delaying getting a hearing aid, you're actually depriving your brain of sensory information? That's, yeah. If you're not getting your hearing addressed, you're actually maybe depriving your brain of sensory information, and that can kind of lead to cognitive problems. So addressing hearing impairment turns out to be really important. Addressing depression, it's really common, can be done, and then promoting physical activity. These are all things that are related to your risk for dementia. And then other things medically. If you have diabetes, taking good care of that. High blood pressure, keeping that under control, cholesterol, smoking, obesity, excessive alcohol. And another thing we're worried about, but kind of monitoring, is social isolation. Again, kind of this idea that your brain needs the sensory stimulation to kind of keep it running. So what about Parkinson's and Parkinsonism? Something I think about a lot is I think that a lot of the patients I see are good at recognizing the symptoms, but there's a subset of patients I'm not seeing until very late. I think that they probably had Parkinson's for years before they've got to my office, and I'm the first neurologist seeing them. Why is that? Well, in some cases, I think it might have to do historically with race and ethnicity, and it could be in some parts of our country we don't have enough neurologists. And it could also be that we haven't done a good job. A lot of the pictures that are out there show an older white man with Parkinson's. A lot of my women patients are saying, how can I have Parkinson's? That doesn't look like me. So we're trying to do a better job of showing that across the board, there's really no discrimination against race or gender. So this is just a slide to say that Black and Hispanic people are less likely to get diagnosed with Parkinson's, even though we don't think the rates are different. And this is a complicated slide to say that the African American group in red, they kind of rated themselves as less impaired than people who are white, even though they had the same impairment. So I think there's something culturally too, and it's natural to think about, oh, as you get older, you're supposed to slow down, right? So that's something that I see, interestingly, different attitudes among my different patients. I have some patients who are very concerned about very slight slowing, and I have some patients who are very slow and nobody has really said anything about it because they just thought that's what you're supposed to do. So we don't know a whole lot about different racial and ethnic groups, but this one I'm just using as an example because African Americans, we just have a little bit more information of. As I mentioned, I see this in my clinic. They come to me, they get recognized later in their disease course. Their care isn't quite as adherent. We have a little set of quality care indicators that we all try to follow, that once a year we're checking in with you about various topics. They're not surviving as long as other people. They're having higher rates of dementia. They don't use PD medicines as much. There might be some, who knows, there might be some trust issues. There might be some issues related to not getting to see a neurologist. They don't get as much treatment for depression, and they don't use physical and occupational therapies much. Again, is it related to an availability issue? Maybe they just don't have as many programs in their communities that they're knowing about, or maybe the access and the information is just lacking to begin with. And then we just know even less about our other groups like Hispanic, Latino, Native American, Asian, etc. Okay, so I'm bringing this up because even though we're addressing a lot of the motor symptoms, It's a busy slide, but I want to just point out that when they surveyed a bunch of people with Parkinson's, and I really like this kind of research where they're actually getting the ideas and beliefs and opinions of people with Parkinson's. Even though the motor symptoms like the tremor and the balance and the movement issues are a big problem for half of them, more than a third of them said what actually concerns them most is more of the non-motor stuff, like the sleep and the fatigue and the cognitive function and the bladder and bowel problems. So that is a lot of what we spend time with. And then we also, which I will tell you later on about, we also have colleagues who can help us, because it really takes a team to kind of get some of this stuff addressed. The first one I will say that's a big one is depression and anxiety. They're really common in Parkinson's, and most of the time they're sort of mild, but they're definitely unmistakably present. We think that probably about 30 to 40% have depressive symptoms at any and feelings of anxiety at any particular time, and some of that is persistent enough that we call it a disorder. And there might be other factors, obviously, if they're uncomfortable, if they're not having they're just like constipation is just really a problem. It's just all so discouraging. That's natural. That's sort of what we call an adjustment disorder, meaning it's taking time to adjust to some of the challenges of having Parkinson's. But there are ways around that, and people, once they get that resolved, they're better again. But if for something that's really persisting, you might think about medicines, and the SSRIs and the tricyclic antidepressants are common oral medications for depression that we give. We think about side effect profiles when trying to pick and choose what might be good for one person versus another. One of the medicines we use to treat Parkinson's are called dopamine agonists. In the 80s and 90s, the companies developing drugs said, hey, what if we had more options besides just that L-DOPA? And so they created medicines to look a lot like dopamine. And they do work, they are helpful, but they can have some significant side effects. But sometimes we use this to our advantage in that sometimes there's some mood lifting properties. If someone develops an issue with their dopamine agonist, which I'll get to in a second, that's on the flip side of that. It's that they start to get a little too enthusiastic about certain things like sex, gambling, food, etc. So we pay a close attention to that when we give someone those medicines. And then there's a lot to be said for non-medication treatments. Cognitive behavioral therapy can be really useful. Some people don't really like the idea of therapy. That's okay. There's other options. But I think an increasing problem is that there's just a shortage of people, shortage of therapists and counselors that can help people with Parkinson's and older adults in general. And then finally, there's probably a lot to be said about exercise and wellness classes. It checks off a few boxes, right? You get more physical activity, you get the social stimulation, and you're also improving sort of your ability to feel excited about something and look forward to something. All right, let's get to another issue, sleep. So there's a lot of ways you can sleep poorly, and we all know that as we get older, our sleep just in general becomes harder. You could have trouble falling asleep at the beginning. You could have trouble staying asleep. You could also have your legs kind of kicking when you're sleeping, and that might be disrupting your sleep without you even realizing it. Or more significantly, in the dream phase of our sleep that we go through every night, normally our body stays nice and still, so we're not, actually parachuting out of a plane. But in Parkinson's, the neurons that control that movement are actually also not working great. And so sometimes people imagine dreaming of a burglar, they might actually grab something and hit that person, which might be their poor spouse in their bed. So this is something we really keep a close eye on, and that could also be leading to sleep problems. You could have sleep apnea, just like any older person, any adult really, it doesn't have to be an older adult. And you could have physical discomfort from the Parkinson's. So we try to address that. Is there a way to dose the medication such that there's a little bit less physical motor discomfort at the time of sleep? So getting to how do we take care of these kinds of complicated conditions? Well, we have felt like it's really best in a team, not just from our perspective, but I think patients have told us they really enjoy that. Obviously, if your Parkinson's is not that complicated at the beginning, it might not really be necessary. But at some point, it's useful to kind of have the option to kind of dip into this and then come back out. Where I really see things, honestly, is that I'd like us neurologists to coordinate better with primary care docs. But we all know primary care docs are very busy in this, and there's a shortage of them. And so sometimes our patients end up sort of seeing their neurologist for a lot of the issues that they might have previously been seeing their primary care doctor for. So as we think about how to provide a better service just across not just our center, but like how do we even teach? How do I teach my movement disorder trainees as they go on and start up their own practices and go on to their own centers? What can they do to kind of build a better service around this? And I think it has to involve nurses, patient navigators to kind of get through the system and say, wait, why am I seeing this person? And oh, right, this is the gastro. It gets confusing. You spend your time trying to figure out which appointments you're really going to get some use out of. But I think having a core care coordinator where maybe if you are coming to the clinic on a certain day, you can line a few of these up at the same day. That can be helpful for some patients. Thinking forward into the future, I'd love to see better technology that I can use to monitor some of my patients. I'm talking about blood pressure or sleep. We have those devices. There's a lot of innovation out there. How do we get that into the clinic and make it useful for doctors and nurses and patients and families? And then I like to use like telemedicine. If you can get on Zoom, there's an issue. We can talk about it on phone, but sometimes having the video there just to have that face-to-face for a quick encounter is really useful. And then from my perspective, I want to understand, are we doing a good job for as many people as we can, irrespective of where they live, what race they are, what sex they are? And so having people kind of be a part of an anonymous registry so we can track, are we getting these people to enough physical therapy? Are we getting these people enough help for their depression, and so on and so forth? Okay, so an example of this is our team at the BI. We actually have had wellness programs and this annual patient symposium that used to be attended in droves in person, but then COVID came, so it's become Zoom/hybrid. There's another one coming up actually this month. It'll be held partly in person and on Zoom, but they've been popular because we can get speakers to come and talk about kind of contemporary issues. What are they hearing in the news about a new treatment? Or we had one year, frankly, a symposium about, media hype about all every day there's a cure for Parkinson's in the news. And it's sort of like, okay, yeah, gee, I heard that one before. So what is really meaningful and what is really just, okay, let's see. So those are the kinds of talks that we'll give. We've had a little collaboration with the Jewish community centers, and it would be great to expand to other community centers and not just be so concentrated in one area. The JCC is over at Newton, and then the Jewish Children and Family Services up in Waltham. But we're also seeing, just apart from us, we're seeing really great strides made by other groups. There's a nice foundation called the American Parkinson's Disease Association. They have a Massachusetts chapter. They support a lot of support groups and help direct people to get to wellness classes that are independent of anything that any one medical center does. So that's good. Group exercise, care partner support. We offer some clinical research and even some Uber transportation, which I'll get to. But community grants, this is, I mentioned the American Parkinson's Disease Association. They give out community grants for people to develop programs that can be done locally for people with Parkinson's. At Beth Israel, they've, Rock Steady Boxing is now kind of everywhere. It's really a boxing class that a lot of our patients with Parkinson's really enjoy. It's art. Living alone with Parkinson's, that's an issue for some people. They have questions about that. The LGBTQ community, they don't see themselves represented, so they also have questions about how things might apply to them if it's different than other folks. Music, and then also narrative medicine, which is a fancy term for saying there's some healing involved when you tell your own story. And I think that can be therapeutic for some people. But clinical research is important. For many years now, Parkinson's has been a very active space. A lot of people are developing new drugs. We still don't have anything that quite slows down or gets rid of the underlying Parkinson's, much like you think about with cancer. We have a lot of good medicines that can help with the symptoms, and I think that helps people take care of themselves, so I do think it's important. But do I have something that I can definitively say, you need to get on this today because 10 years from now you'll be in a better place than if you didn't? We don't have that. One thing that we like is that some of the clinical research studies are getting a little bit more inclusive in that we're trying to do more clinical research such that you don't have to, or a person doesn't have to leave their home, or they can participate kind of just like a one-time thing and just be observed. And that kind of research is also very informative. This is a very innovative study that the National Institutes of Health funded. That's our government science agency that funds big projects. And hip fractures, everybody gets them. If you have Parkinson's, you're 6 times more likely to have a hip fracture. Whether or not you have osteoporosis. There are medicines for osteoporosis. We just don't give them to people with Parkinson's. We don't know, because we just don't know. Would that be useful or would that not be, even if they didn't have osteoporosis? So this is an example of a study that a person can participate from home. A nurse would come to your house, administer you either the placebo or the bone medication, which is called zoledronic acid, and they follow you. And in a few years, we'll know, should we be giving everybody a bone medication? Everybody with Parkinson's a bone medication. So that's an important question. I talked about genes earlier. We know a lot of genes, but as I mentioned, scientists and even drug companies have big genetic departments because they're looking for what other ways can we manipulate the biology so that we get slower progression of Parkinson's. But predominantly a lot of the research was just coming from the US, North America, Canada, and Europe. And it's predominantly, white people. But then we're starting to get some more information from Asian countries. And now we want to include the South American and African countries because our gene diversity is what makes our biology so interesting. And so getting more people to just agree to having a blood sample and being tested for genes helps our collective research group, and this is through the Parkinson's Foundation, understand what kinds of genetic variants do people have out there and which ones look promising for trying to develop a drug to treat. So that's another one that people can come in and get blood tested for and even get a free Uber ride if they wanted to because the foundation is paying for it. So that's really all I had to say today. I'm just leaving my information up here for you. Our coordinator, Hannah Babcock, is great. She's a great resource in terms of information for our wellness programs, but also for clinical research and connecting people in the community. We have mainly a Boston phone number that I listed up there for Hannah, and then for clinic appointments for Milton is a separate phone number. If there are some communities in need, we know in Massachusetts, even though we've been a pioneer, our state has been a pioneer for healthcare, we know that there's still shortages of things like primary care and even neurologists. So we usually try to prioritize that. And then I mentioned there's free sort of Uber transportation for people if they want to come into Boston to participate in any of these observational studies. Thank you for your time. Hope it was useful.